Hi, everybody. This is the fourth CPC Behavioral Health Workshop for faculty. We have a group here today. You'll see them in a minute. So I just want to thank CPC again for offering these free seminars. These are being recorded, as you know, at home, so that faculty can watch in their pajamas or whenever they have a chance to do this. So welcome. Welcome everyone who's here. I'm just going to go right to our guest speaker, who is Ken Pecoraro, and the theme today is on substance use disorders. So in the classroom especially. Here we go. You don't need this. You don't need it.
Got me? Hello to everybody at home in their pajamas. All right, I'm jealous. So I did one of the speaking gigs and I don't remember what I said, so if I repeat anything, I'm sorry, I forgot what I said last time. So I refrained from using a PowerPoint because I wanted it to make it interactive if we can. So, you know, I do these speaking gigs all the time, and you'd think all the coming up with what to say is not really that hard. The timing is the hardest part. So I always end up bringing too much stuff because I always have this fear that I'm going to be standing there with nothing left to say. So that usually doesn't happen. I probably won't get to all of it. So at any point, I know people don't want to get on camera, but at any point, if you do have a question, please just interrupt and ask a question. So I've been in the addiction field for my whole life, my whole adult life. And I started in the 90s, and it turns out, an old CPC intern is here, so we go back, even then, at that point, 15 years ago, I was in the field 10 years. So I came right out of high school, right into the field in the 90s, and I'll tell you, being in this field for over 25 years, how much it has changed, how much the way the world views addiction has changed. So I wanted to talk a little bit about that, and then also how to deal with kids in real-time situations, because I'm sure that's what's a situation for you. I'm sure kids are coming here high. And when I use the term kid, I always have to put this disclaimer. Kid to me doesn't mean 18 and under. Kid is anyone living a lifestyle that's not an adult lifestyle, and that could go up to like 29, 30 years old. If you're still living at home, smoking weed and doing whatever, you're still kind of living a kid life, so don't get thrown off when I say the word kid. It's just I got to come up with a better term, but that's what I use. Young person, whatever. Student. Okay. I'll probably use all three interchangeably. So some of the things that are just real quick to cover as far as things that have changed is there's a lot of changes in just kids or young people themselves these days, and I'm sure you've seen it. There's certain things that are universal that will never change, but there's a lot of things that are very different about working with young people today, especially in the addiction field. And one of them is we've had to, all of us addiction counselors had to adapt the way we approach addiction, because in the old days, when I say the old days, I'm sure addiction goes back into the beginning of time, but my old days of the 90s, it was still, the internet wasn't out yet, and it was a very different world. So addiction people were viewed as experts. So you got your master's degree and you learned all this stuff and you had all this training, and you went and you were like, here's all this information I'm going to give to you, and the students or the people, whoever you're working with, were like, oh wow, this is really interesting. Nowadays, when you try to approach it from that standpoint with the internet, the kids will tell you more than you know about yourself. And unfortunately, a lot of what they learn is inaccurate, but the internet has everything, and a lot of it is accurate. Some of the best learning comes from people who are actually living the life. You want to learn about prescription drugs? Go to somebody who's addicted to prescription drugs. That's where they'll tell you the color, the size, what numbers are written on them, which ones you can chew, which ones you get. That's how you learn everything. So, but this whole notion that I'm the expert, you're going to come to me and I'm going to show you the path to recovery it's not like that. It's you're the expert on you, and everybody's different, and we're going to treat everybody differently and let each person be the expert on themselves and kind of guide them along that. So just as a counselor, it's much more about engagement and working with people where they are than as opposed to being the bearer of the secret knowledge to recovery. So a lot of that came from the 12-step model, which was people went through the 12 steps and they're like, oh, this worked for me, now let me try this on you, and it works, which works really well, provided the person that you're trying to teach wants to learn the 12 steps. We now know that there is a lot of people that are like, I don't care, you could stand on your head and tell me the 12 steps, I'm not doing it. So we have to adapt our approach. So that's one of the things that's very different. Another thing about today's youth today is attitudes are a little different. There's always, again, the addiction crowd has always been a challenging bunch to work with. But it seems to be nowadays, there's a lot less of fear out there. I don't know if that's because of the internet, but it's like the young people of today have called the legal system's bluff, in so to speak. So we used to be able to say, well, if you do these substances, you're going to get in trouble, and then the judge will send you to jail, and they'd be, oh my God, I don't want to go to jail, and it was a big deterrent. Now this generation's like, let me see what happens, and like a lot of times nothing really happens, and they found out like they called the legal system's bluff. It's a way overworked, overwhelmed legal system. There's not enough. It takes a lot more to go to the consequences are, and that's actually a good thing because jail is not a place for people on drugs. So it used to be a little bit more to the other extreme. Let's put everybody in jail. Now it's, but now sending people to treatment is what really works. But as far as dealing with the attitudes with young people, it's a little more challenging. Again, if you're not ready to meet people where they're at. And I'm going to talk about the term being called, it's my own term, but I use it all the time, being respectfully suspicious. So we're going to talk about scenarios that you're going to have to confront different things or to address. Let's not even use the word confront because that's too confrontational, but to address certain things. And there's a way to do it. You can get away with a lot of things if you're respectfully suspicious. So we'll get more into that later. But, and one of the other things is, as far as families, there's still intact families out there, but as a general rule, the depth and prevalence of family dysfunction seems to be a little deeper nowadays. Now, I mean, you'll get, everybody's got addiction in their family, but now you look at it and people have a lot of it in their family. There's some people who, like grandpa has been to jail and, they have family members in jail, you get everything. And in the old AA philosophy, they used to say jails, institutions, or death. And then now there's a group out there that's like, jails, institutions, or death, so what? You know what I mean? They don't want to go to jail. They don't want to die, but they're not necessarily have that fear that some of the younger generation of the past did. So another thing very different about today is the increased availability of substances. It's so much harder. It used to be you'd have to be the real motivated drug user to go get heroin, and nowadays it is not like that. In Middletown, you'd be blown away how much heroin there is in this town. In all the towns, it's everywhere. I don't care where you live. It's in your town too. I mean, I live in Brick. It's all over Brick. It's everywhere. A lot of people in Brick don't realize. I live 5 minutes away from a methadone clinic with over 300 patients in it. I think a lot of people don't even realize that. Middletown has one too. So not that there's anything wrong with that. It's drug use is everywhere. The news is not overblowing it. I've been working in Middletown at CPC for over 18 years, and the prevalence of drug use in this area is especially opiates. That's our number one admission for coming in. So another thing is, heroin, they use the term game changer. The people love to throw that term around, but really heroin is really a game changer. It's changed the rules. It's changed the way we do everything. And does anybody know why? Here, you can shout it out from the audience without having your face on camera. What's the number one reason why heroin's a game changer?
So addictive? Cheap.
Super addictive. That's part of the reason.
So easy to get.
Easy to get, but what's the big one that's got everybody scared? Cheap, and it leads to what's the worst thing that can happen? It kills people. That has woken the world up. It's like it used to be all these different approaches to say, oh, let's be hard on drugs or let's use tough love. But with heroin, you send somebody out there who's using and just say, oh, I'm done with you. These people are dying. And now it's not just an inner city thing. People are dying everywhere. Rich, poor, black, white, young, old. There has been a lot of death. And so that has necessitated everyone to say, okay, we need to approach this differently. So that's one of the biggest moves in the field is from this abstinence-based paradigm to a harm reduction paradigm. CPC has always been a harm reduction since I've been there, since 2001. We've always accepted people on methadone, and we realize it's a process. We want abstinence, we strive for it, and it's nice to have, but if someone is taking their time getting there, then that's how you work with them, and then you let people go at the pace that they're, because the alternative with heroin is you start kicking people out and they start dying, and it's a lot different. I'm sure now, without showing hands, everybody here knows somebody who knows somebody who's died from heroin. It's because there's that many people have died. It's outrageous how many people have died. And sometimes some of the stories you hear, it's like, it's not, the prototypical junkie that dies. It's the housewife. It's the, it's all kinds of, all of us counselors, I say this a lot, all of counselors, to a degree, we're all traumatized because we've all had so many people die. You know, back when Fidel, when you were there, people weren't dying like they are now. I mean, they are dying. It is, and there's nothing like making that phone call like, well, hey, where's so-and-so? And you found out they died, you know, over the weekend, and it's crazy. So heroin is definitely a game changer. And as far as it being around, there used to be that brave kid in the neighborhood who would get on the train, go to Newark, and get enough heroin for everybody and bring it back and sell it, make a ton of money doing it. But nowadays, that's not necessary anymore. There's enough of it right at the same price locally. Okay, so one of the paradigm shift is we have to be realistic instead of having ideals. So ideals are important, and recovery used to be based on an ideal. The ideal was the person's going to enter treatment and they're going to abstain 100% from drugs. They're going to go to 90 meetings in 90 days, change all their habits, and like all these things that we wanted to everybody to do. And we found out now that people don't change like that. And an example I use all the time, and I don't know if I shared this one already, but the going to doctor, did I use this last time? That's a good one. It's worth repeating if I didn't. So you go to the doctor, and it's a good thing to try to have, one of the best things you could do is to have empathy. And it's good to think of real life scenarios in your life, because a lot of people want to judge people that are addicted to drugs. And to be able to use empathy, a good way to use empathy is the going to doctor model. So you go to the doctor, and the doctor says, oh no, you're pre-diabetic. What are we going to do? And you're like, oh, I'm pre-diabetic. Tell me what to do, doc. And the doc tells you, okay, I want you to lose this many pounds. I want you to stop eating fast food. I want you to start eating kale and taking fish oil and take this medicine, and I want you to run 3 times a week and go on this website and sign up for the diabetes support group. And you know, it gives you a list, and you're like, you can't get them all. It gives you a list of 20 things to do, and says, here, go do them. So you do these things, you won't progress to diabetes. So you go home, you're all motivated. I'm going to do everything on this list. And in a week or two, how many things do you think the average person is doing on that list? Yeah, 2 or 3, maybe a go-getter's doing 4 or 5, but nobody's doing it all. Yet, we expect, we have somebody come into a treatment place, somebody who needs treatment, and we're going to tell them, change your friends and start doing yoga and meditate, and we want you to believe in God and do the 12 steps and take medicine, and we expect them to do all those things, and when they don't do it, the treatment community used to get mad. Why aren't you doing all those things? Yet, people change the same way. So you see the analogy. So that's how we focus on what's realistic. If you can get somebody to just change a little bit. So, but I want to bring this about to scenarios for you guys. But a good way to look at addiction is when I first learned about addiction, they wanted to give us an illustration to say why addiction is a disease. And it really is a disease. It fits the model perfectly. So real quick, my handwriting's awful, so you guys in the pajamas are probably going to read it anyway. So, so when you think about it, you want to compare addiction, and you compare it to a disease like cancer. Cancer's a nice one that hits home with everybody, because everybody, you know, cancer's also a game changer, right? So you figure, let's see what parallels they have. So we're going to look at a disease model. So cancer has symptoms, right? That's how the doctor knows you have cancer. Addiction also has symptoms. You know, tolerance, losing control, using more than you wanted to. These are different symptoms. Think cancer is chronic, right? It's long lasting. You don't have to say, oh, I had cancer for the weekend, but now I'm better. No. Same thing with addiction. You don't get I was addicted to crack during Christmas break, but now I'm great. You know, so it's a chronic. It's not an acute situation. Cancer, if you don't get treatment, it's potentially fatal, right? Potentially, especially if you don't get treatment for addiction, same thing, potentially fatal. So you see all the parallels. There's many of them. You know, if you relapse, if you don't make the life changes. So that helps illustrate. Wow, it is a disease. But it's funny. I don't like this model. I don't like this example. I do believe it's a disease, but I'll give you a better example. So what happens what do you think the first reaction to somebody is when they find out they have cancer? You know, they walk in the office and the doctor says they have cancer. What do you think the first, you can shout it out so you don't get on TV. What's that? Denial, right? Anything serious, HIV. You think about 9/11, you know, how many weeks after you stare at that New York skyline, you're like, I can't believe the Twin Towers aren't there anymore. You know, I still get it. You know, so denial is the natural reaction to any bad news. So if you tell somebody they can't, it doesn't sit well. So if you're comparing addiction to cancer, you get the same type of reaction. People don't want to believe that nobody wants to believe that they're not in control. To say, I really think you're an addict. No, your first line of defense is to say, no, I'm not, and here's all the reasons why. So it never really works that way. I think it's a lot. If you're going to look at it, comparing it to another disease, I like to compare it to a cold. Right? It's hard to argue that a cold is a disease, right? But a cold has a big, broad spectrum. So a cold you can have the sniffles, the beginning of a cold, the little sore throat, whatever, and then cold at full progression, if I can even spell this, pneumonia, right? And there's everything in between. There's a whole host, right? And the thing about the sniffles is, what did Grandma say to you when you were a kid and you had the sniffles and you didn't take care of it? What would happen? You're going to catch pneumonia. So it's the same thing. So the same, if you look at addiction, it's the same way. You get the weekend pot smoker or drinker or whatever, dabbling, gets into a little bit of trouble. Maybe they're in the sniffles area. But sometimes if they don't take care of it, they can end up at that pneumonia point where it's, because it is one of the things that they both have in common. They are progressive. So when you use that illustration, people tend to, I've used that a million times, but especially with teenagers, they'll be like, yeah, okay, I can handle that. I gotta, it's a lot easier to buy the fact that you have a cold as opposed to, I hate rooms without clocks, by the way. All right, use the phone. All right, wasn't checking my message, I was looking for the phone. All right.
I'll give you a warning.
Talk about addiction. I mean, that's a whole nother one. All right, so yeah, speaking of, nobody's picked up their phone, it's good. All right, okay, so talked about the cold analogy, and one of the things that makes it, especially when you're talking with young people, that's one of the hardest groups to talk about addiction with, is because of a natural thing occurs in most young people. It's called the optimism bias. Has everyone ever heard of the optimism bias? It's a fascinating thing. It's that tendency to say it's not going to happen to me, and it's actually a needed thing. Because could you imagine if you believed every possible bad thing that could happen to you, and you're like, oh, it's going to happen to you? If you need a little bit of optimism bias, or you're going to walk around being a hypochondriac and never leave your house. So it's actually a natural defense of things to say, like, oh, I'm going to be the kid. And every kid says it, and thank God. So let's go with smoking weed is the most common thing, right? Especially with the young people. Drinking too, but let's go with smoking weed. And every kid said, I'm just going to smoke weed, and when push comes to shove and I need to stop and get serious with life, I'm going to do it. Fortunately, in most cases, that does happen. That's the norm. Smoke some weed when you're young, get a little more serious life, or whatever, and say, you know what, I have too many responsibilities. But unfortunately, not everybody. That's not how it works for everybody. There's people who build that dependency on it, in the sense that now they're not just smoking weed for having a good time. They're smoking weed because it's making a connection of, wow, this weed helps me get through the day, and some people smoke weed forever, and that's it. That weed helps them get through the day. But then there's some people who say, you know what? It's not enough. So let me throw some Xanax on there. Let me throw a few painkillers on there, and it progresses. So it's not necessarily fair how it works for each person, because there's a lot of factors: genetic predisposition, social factors as to who progresses and who doesn't. So, all right. Any questions on this? I know I'm a fast talker. All right, guys, the pajama folks can't ask questions. All right. Shouldn't have told me that. Now I'm like fixated on it, right?
My fault.
All right. They say imagine everybody in their underwear, but now I'm imagining everybody in their pajamas. I guess that's a lot better, right? All right. Depending on what kind of jammies you wear. All right. Okay, we talked about it. So most people who won't come. So another good example is to show how most people won't become addicted. So we use the DSM-5 to diagnose people for different substance use disorders. So the specific criteria. There's actually 12 or I forget, 13, 11, whatever. I should know that, but I forget. But there's a bunch, good quarter of a page worth of them. So if you took the DSM-5 on a Saturday night to, let's say, a university where a lot of people are staying, or even Brookdale, took it to the average Brookdale student who's under 30 and got him on a Saturday night, and you started doing DSM on him, what percentage do you think would meet the criteria for a substance use disorder? It could be 60, 70, 80% on that Saturday night, in that lifestyle, but 10 years later, how many of them are still going to have that meet the criteria? It's going to basically drop back to the national norm. But again, the problem is with young people, with any disease, we talked about that pre-diabetic, you don't know necessarily who's going to progress. So when you're talking about young people, you want to play it safe, and it's better to intervene, because it's better to intervene with someone who didn't necessarily need it than it is to ignore it and let somebody to progress. Because once it gets to that point where it's out of control, it's a much different ball game. And unfortunately, working at CPC for all these years, we have this program called Project Insight. It's like probably the easiest program. Did we have it back in those days? I don't even know if we had it. We've had it for about 10 years. I keep calling on Fidelity Bazar. What? It was 12 years ago, right? We got to get them on camera at some point. But just kidding. But Project Insight was for kids. It's an early intervention program. It's for kids that just started dabbling. You know, got drunk and went to the prom, but you don't want to put the kid in a program because it's a little more serious. And quite often you'll get a kid in that program, and I call them the "Just Give Me My Weed" kids. You know, the kid will say, "Just male or female, just give me my weed, leave me alone, and I'll be happy." And everybody should just leave me alone, let me smoke a weed. And I can't tell you how many times that we have a walk-in clinic at CPC where new intakes come in, and I'll see a kid, 23, 24, 25, and he was one of those "Just Give Me My Weed" kids, and I'll be like, what happened? And they always say the same thing: "I never saw this coming." No one ever has that in their head that one day I'm going to be sticking a needle in my arm. And one of the funny, it's a sad story, but a kid that actually really illustrated that to me is a kid who's now deceased. And he used to be a "Just Give Me My Weed" kid, and he got caught in school smoking weed. And he had a great family. Family was engaged in treatment, and we used to talk about, you know, in the potential, if you don't watch this could get worse. And no, never going to happen to me, never happened to me. And this kid calls me up. He came to treatment twice in his teens. And the second time I was like, okay, now it's happening again, whatever. But he was, you know, he did good, and he would actually get through treatment, do what he had to do to close it successfully, but then go back to his lifestyle. Came back in his 20s, and he's like, "You're not going to believe it." He's like, I'm the cliche." I'm like, "Well, tell me the story." You know, he's like, "I was driving too fast on the highway. I won't say which highway." And he exited and crashed the car and hurt his hand. Got put on pain medicine. And he's like, "Everything was fine in the beginning, and then I got a hunger for that pain medicine, because there's something about those opiates that take it." Remember, heroin's a game changer. Opiates are a game changer. It took it to a next level. Next thing you know, going to, you know, different cities to get his dope, whatever, full-blown heroin. Sadly, he ended up. I thought it was very humble of him to come back, and he did well. But he left CPC. Not using for a significant time period, about 6 months. And one day I forgot, I just called, the dad called me, and he had died. But it was like a one-time, they said he was doing great, he was working, he was everything, and just tried one more time, and that one more time got him. Because now with fentanyl, that whole thing's not overblown. Fentanyl can kill you anytime. That's not a scare tactic. Every time you put that opioid in your body, you're definitely running a chance of dying because of the fentanyl. You don't have to use more or anything. It's crazy. All right. You know, they say that the movement is towards medication-assisted treatment, which is giving people medicine to keep them to help with the cravings. CPC, we do it. We give it out because especially when you come off a period of abstinence, they say the first 2 weeks after coming out of like a jail or rehab, depending on your statistics, they're talking 100 and something that I've heard is 140 times more likely chance of a fatal overdose in those first 2 weeks coming out of jail, coming out of a rehab. So that's why putting people on medicine on their way out, it decreases it a lot. Okay. All right. No questions so far? So just like it says in my head, just with any disease, you want to intervene when the signs are present. So. Important point on the sixth point is people get hung up on amount and frequency used, which is important. It is important. Substance use evaluation, one of the first things you start getting into is how much is someone using, it's important data to collect, but you guys aren't going to be getting involved with people on that level. It's not necessarily how much they're using, which is important, but a lot of times it's what's happening to people when they're using. And just something as simple as, are people complaining about your use? That's such a big thing. There's simple screening tools, and one of them is, if anybody's complaining about your use, that's something to note. And I always like to say, the closer in age that person is complaining about you, the more serious it is. So for example, if your grandma is complaining about your use, it's important, but if your friends are getting freaked out by your use, because I've had people say, yeah, my friends, when I do whatever, like they're like, dude, you better slow down. Like I'm like, oh, if your friends are telling you, those are the ones that are usually like, go, 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 come on, you're dancing naked with the lampshade on your head, and they're like, yeah, yeah. But if they're starting to get worried, that's a really serious worry. So I wanted to start to get into some of this practical stuff for you guys. So there are risk factors. You're not going to always know this with students you're working at, but one huge risk factor is family history of substance use. We know for sure it's genetic. You don't need a microscope to know that it's genetic. You study adoption studies, and you take somebody out of a family with addiction, put them in a family with no addiction, all the right thing, going to school, all the social determinants that make someone have a higher chance of having a healthy life, still higher instances of addiction. Clearly, it's being passed on through genes. Early onset is one of the biggest also good ones also. So if you have kids of yourself, the whole the idea of just let them do what they're going to do them anyway, it's not a good idea. Not a good idea. The longer you can delay that first use, the better chance you have for that with any disease. The earlier it starts, the harder it is to beat. You think about if somebody beats somebody up with a baseball bat in the legs when they're 7, they might not walk right for the rest of their life. It happens when you're older. You have more of a little chance to make the comeback. That actually starts to work against itself once you start getting really old, but probably not the greatest analogy. But still, early onset is huge. Obviously, what their peer group is like and their support system, people with more support, more reasons, more of those social factors, those things make a difference. Someone who does care about how they're gonna do in school and their career, that those motivators keep people from progressing. And obviously, if somebody has a co-occurring mental health disorder, which is the norm nowadays in the addiction world, at CPC, about 75% of everybody in the addiction department has a diagnosable mental health issue as well. And that is a huge risk factor. Because now, when you're using, like I said before, when you're using to deal with as almost a medicine, they say self-medication, that's a lot harder habit to break than someone who's just using for pleasure. And there's a plague on the world right now. It's the plague of anxiety. And people don't talk about, they talk about the opioid epidemic, the anxiety. I have my own theory as to why the world is so anxious. And so I don't know, but it makes sense to everybody I say it to. You think about the old days when you pretty much had to just worry about, like, where am I going to get some food and grow the crops, and and you had your neighborhood, and you talked to, you walked over to people in everybody's community. There's a lot less to be anxious about. Yeah, you had to worry about like a wolf coming and eating you or something. But on a general day-to-day basis, you know what I mean? Like it was. But now think about what it's like to be a kid. I feel so bad for my own kids. I'm like, what a world. It's too much. It's too much at once. And everybody's anxious because of it. It's like a consequence of this information age. To always know what's going on all the time and be connected to everything. It's like, I don't know that our brain was wired for that. It's too much. But because of anxiety, it's one of the biggest influencers to using. Anybody that you hear that all the time. It helps me with my anxiety. I smoke weed for my anxiety. People that use heroin. There's one guy who works at CPC who was actually one of my clients years ago, and he's like, I know for the rest of my life I will never feel freedom from anxiety like I did from heroin. I have to live knowing that. And he's like, I wish I never felt it, because it's that one time in my life I felt fully at peace and okay with everything, because it's that powerful. But maybe we're not supposed to feel that way. So there's a lot of when you're looking at mental health and addiction, there's a lot of overlap. So I listed a whole bunch of symptoms: mood swings, irritability. Sometimes you don't know which is it. Is it mental health, and is it addiction? So there tends to be two schools of thought when it comes to, especially in the counseling world. And the world is working towards integration, which is looking at it as one thing. Mental health, substance use, it's all in your head as far as a mental situation. Let's all work together, and because you still have your addiction camp and your mental health camp. They've come much closer together. If you go back to the 90s, if a place did mental health and addiction, you would think there was like the Berlin Wall in the middle of the agency. Like, that's the mental health side, and that's the addiction. Don't come over there. You know, you didn't even talk to those people. Now, it's much more integrated. But people tend to have a bias towards what their leaning is. So there's a lot of people who are very comfortable with asking about mental health, about depression, about suicide, and they're afraid to ask about addiction. And there's the addiction people who will ask you about every drug they ever tried and have no problem with it, but they're afraid to ask about depression. You should be comfortable and ready to ask with both. And one of the biggest fears, I was going to get to this later, but I don't want to miss this one, is there's reasons why people don't ask. So now we're getting into things for you guys. You should ask. And people, there's a lot of, I understand why you wouldn't want to ask, because the fears why you want to ask are real. There's a lot of them. So one of them that comes up, I didn't put these on here, but is I'm not qualified. Why should I ask about addiction or mental health? I'm not qualified to do anything about it, which may be true, but we're only putting it out there to ask about it. We're not asking you to treat it. You know, if you ask about it, whether you're qualified or not, just like you might ask somebody about, let's using diabetes. Whatever, you're putting on a lot of weight and you seem like you're doing like whatever. Maybe you should get a physical. You know what I mean? Obviously, you'd want to ask that in a way that's respectfully suspicious, like I talked about. You have to be respectful about it, but even if you're going to be suspicious, you have to be respectful in how you ask. Because even if you ask a question like that, my person say, "Yeah, mind your own effing business," But it's all in how you ask. But the important thing is, even if you don't feel qualified, you should still ask the questions. You're viewed in a lot of these kids, students, whatever, lives as someone who, I'm not saying the onus is on you to ask, but a lot of people view you guys as somebody who they might want to ask. And I'm a firm believer in when somebody is losing control, they want you to ask.
Well, Ken,
they might not say it.
I have to interrupt for a second, because
Yes,
Ken,
please.
the college policy right now, counselors in the room, are we allowed to ask a student, are you having trouble with addiction? I don't think we are. Are we or aren't we? Anybody know?
I don't know. Says who?
Is that okay? So we can't say you should go to a counselor. We can just offer the counseling services we have. So I know isn't that a rule that you can't say you really need to go to a counselor? I've always been told that we should say that there are services here available at the college to help. And does anybody know what I'm talking about? Like, I was always trained to keep it general, right, Debbie? And to keep it general, to keep it open.
You can still do it, but you got to work within the policy. So maybe don't use the word addiction, but to pull somebody aside and say, is everything all right?
Yeah, that's for sure.
You look a little sleepy there. Whatever. That's a human to a human. You're not breaking any policy there. And if the person wants to volunteer that information, and they might even say no, but now they know this is a person I can go back and talk to later. And so that leads to reason number 2, why people don't do it. So the fear factor. But a good example with the fear factor is people here, I'm sure some people here have kids, right? And there's 2 ways to raise kids. You can be a proactive parent or you can be a reactive parent. And we know it's better to be proactive. When a kid's crying and say, give me another cookie, and you could say, I'm tired, here, just ate the damn cookie, and then yes, you've alleviated the situation now, the easy way. You were the reactive parent. But it's better to be proactive and to deal with that situation ahead of time. Like, no, I gave you enough cookies, and even if you cry and kick and scream, I can't give you another one, whatever. And the thing is, the long-term result is that kid's going to be a more well-adjusted kid. The same thing with dealing with the problems of your students. You could look the other way and just hope that they all go away, but if there really is a problem, it's not going to go away. It's going to just get worse. So you're better off dealing with it up front and be proactive. I'm a firm believer in that. So the I'm not qualified thing, I wouldn't worry about it. Again, just be respectful. I say that all the time. I've trained a lot of people. I'm worried about asking that. No, when I talk about being respectfully suspicious, that's saying, I got to tell you, from a counselor's perspective, let's say I'm running a group and I think somebody in the group is high, right? To say, you're high, get out of my group, that's going to only make him hate me and probably other people in the group get a little frazzled as well. But to say, I am a counselor and it is my job to be suspicious here, just to let you know, you look a little sleep tired today, something doesn't seem right, is everything okay? Or even to pull them aside. That's being respectfully suspicious, letting them know, it's okay, I'm just being suspicious because I care, but I'm going to be respectful about it. So it's all in the delivery. It's all in the delivery. So you don't have to be afraid. The other reason is I don't want to open up that can of worms. And you hear that all the time. But again, you're not doing anybody a favor using that example of ignoring a child that's acting out. by ignoring the behavior, it's not going to go away. Open up the can of worms. And another one is, this one I hear all the time in high schools all the time. I didn't bring up the kids' drug use because I didn't want to hurt rapport. And believe it or not, on the front end, yeah, you might feel like you're hurting rapport. You might somebody might be like, screw you, but believe it or not, working with people, you'd be surprised how many people, how many kids that are using, you gain their respect because you brought it up, as long as you didn't do it in a jerky way. So you're not really going to hurt rapport. You might feel like it in the beginning. You might get a little pushback, but kids and young people appreciate it. More often, that you're going to more likely to gain respect by bringing it up. So, all right. Where am I on time? Okay, 2:41. So one thing is, so let's say you finally get the courage to bring it up to somebody, and you're following policy, and you say, "Is everything all right?" And they say no, or they lead on. Maybe they let some information.
Ken, I had a student say, okay. "Oh yeah, at the break, every time we had a break, he would come back," and I'm like, "Oh man, he is stoned." So I talked to him about it, and he admitted it. He was like proud of it. He's like, "Yeah, I go out in my car," and it was like, "What do you do? What do you say?" But because he was very, he was direct. He's like, "Yep, I'm going out in my car. I'm smoking pot," and I was like, "Oh my God, what do I do?" So I just thought I'd throw an example out there.
I love honesty. That's great.
I love honesty.
First thing I'd say, I tell the kid, I thank you for being honest. That's very cool of you to be honest. Again, it depends on the policy as far as here, but I would let them know that I'd prefer you didn't come in here high. I really appreciate that you told me the truth, but if it does disrupt the class or whatever, most likely if he's doing it, he's probably using it more of a medicinal type situation.
Yeah, it was disrupting his work. He was with it in the beginning of class, and then after break he would work at the computer a little bit, but he was just definitely
so that would be somebody
looser.
I might play let's make a deal with. All right, you're grown up, you're going to smoke weed, that's good, but if it starts, this conversation's going to come back, because I care about you and I want you to pass this class. Now, and I do appreciate the honesty, but now that it's out there, if things go bad, we're going to have to talk about this again, So, and just something like that, being as cool about it as possible, but at the same time, not just leaving it alone. So I would want to bring that up with him again, especially if he is not doing in school doing well, because it's in both your interests if he passes, right?
Right. Oh yeah. I don't know if you're going to open up to questions or other examples. I just threw mine. Does anybody else have a student in mind that they want to talk about? Yeah. I mean, not specifically, but a person. Here you go.
Hi, I'm Kathy Blackburn, and I teach speech. Didn't want to get you nervous. Don't worry about it. You're doing fine. So we have the vaping thing has come up a lot in my classes because it's controversial, and they talk about it a lot. And a lot of the students are beginning to admit, and I mean like publicly, I'll say, how many of you vape pot? And almost like in my Tuesday class, 3/4 of the hands went up. And they love vaping because you cannot smell the pot. You cannot even see the vaping thing, right? So when they're in the bathroom, smell. And of course, we all know that that's really dangerous now, that the lung disease, right, the lung ailment, that's the CDC is coming out and saying it's probably somewhat pot-related, and it's the illegal pot you're getting, it's vitamin E. And I think they've heard that, but like you said, it's just pot is what they're saying to me. So what do I say to them?
Yeah, that subject comes up. Great question. That subject comes up all the time. There's nothing you can say to them that's going to make them say, "Oh man, wow, I'm not going to smoke pot anymore." Like it's too powerful of a thing. But to get people to think about it, and again, I don't know how much time you want to dedicate, but like in a counseling setting, because I get that all the time. They just give me my, fortunately, there are people that are, like I said, who aren't going to progress. But to consider the fact that maybe it will, and if you're talking about somebody young who's smoking to get through the day, and have them project to the fact that, well, one day you're going to be working, so you better hope you get a job where you could smoke, right? What's going to happen if you don't? A good example would be what I've used with kids a lot of times is to break down the optimism bias that it's not going to happen to me. if you take, I call it the time travel example. So I've had many times a bunch of kids in the room, and I'm just going to smoke my weed, and it's never going to happen to me. Nothing's ever going to happen to me. And I say, okay, let's go back in time. So let's go. You're all 9 years old right now, right? And you're in the DARE program. So now be your 9-year-old self right now, okay? All right. So how many kids here are going to get arrested? And, no, not me. No way. Not, how many kids are ever going to smoke cigarettes? No, not me. How many kids are here going to ever be in a program like CPC? No way. That'll never happen to me. So now fast forward to the future. Here you are. It happened to you. You didn't think it was going to happen then. So to at least consider the possibility that it might happen. So to say, all right, that's working for you now, but in 10 years, is it going to work? Even in 5 years? It's not necessarily a long-term solution. It's very hard right now because of all the propaganda. Also, that I like to consider myself a middle-of-the-road guy on a lot of situations. Marijuana being one of them. And there's the marijuana is the devil's school, and you smoke it, and you'll be sticking a needle in your arm tomorrow crew, which is not true. And that's only fueling a lot of falsehoods. But then there's the weed's going to save the world group. Like, let's give it out in kindergarten because it's great and everybody's going to make everybody happy. It's somewhere in the middle. It's somewhere in the middle. Some people are going to be able to use it successfully, just like alcohol, and a hell of a lot of people aren't. And to assume anything is you're leading yourself down the wrong path. So just to get people to look outside of themselves. I don't know if that was a kind of a convoluted answer, but long term. But again, just to get people to consider the possibility that this, because I think that, how would somebody look at, I'm sneaking a couple of drinks in the car? You know what I mean? And would that be okay? Because drinking, give me a couple of drinks. I'm less angry. I should have took a couple of shots before I did this. Why not? But it's not a long-term answer because then now I got to do that all the time. You know what I mean? So. Great question. Comes up all the time. So don't feel frustrated if people aren't walking away from conversations with you going, "Wow, she really taught me." Because it doesn't happen to anybody. It doesn't happen to the Surgeon General. Like you could be this, nobody's walking away. No kid is walking away from a conversation like that. But what else? That was good. Anyone else?
Argument that if you take the alcohol away, what do you replace it with? Almost as if like the onus is on the other person. But this is very personal because this is the person I'm thinking about is someone in my family. So
okay, but it's a great question. No, it's a great. Alcohol. People get into drinking or any drug because people don't use drugs and say, "Oh man, I didn't really that sucked." They do it because that felt good. And so you're saying you're trying to take something away from somebody that feels really good to them. It's something to do on weekends, and it's social life, and you're losing a lot by taking it. So that question is a very valid question, and the people who get better are the ones who answer that question. So the problem is there's no easy answer to that question. It's not like, hey, I'm going to move from smoking crack with prostitutes in a limo on the back on the driveway to Atlantic City, and then to like, I'm gonna knit on the week. It's like there's no comparison. But the thing is, what's that? Limo. Yeah, but I tried to use an extreme. But the thing is, when the fact that person is saying that they're actually on the right track, because if they can find that alternative, it's a miracle. And that's the people that make it, the people that find that thing. But it's not an instant fix. Nothing is going to be like hitting a drink or the joint or but when you find that thing, I've had people succeed with all kinds of things. Like somebody joined a bike riding club and now bike riding is their thing. They're all, getting into shape and buying those spandex and everything. And but it becomes the new addiction. You know what I mean? It's finding that person. Some people get into religion. Some people get into AA. Some people get into helping other people. Some people get into golf, whatever it is. Fishing, yeah. Right.
Woman golf, a man fishing.
Yeah, if you find your thing.
Dead of winter fishing.
Right. Yeah. Well, I grew up with this kid who was without a doubt a fishing addict. He used to, on his lunch break, he's like, there's a lake outside, and he goes fishing on his lunch break at work. I'm like, dude, you are definitely a fishing addict, man. But still, that's a much healthier alternative, and it's a place where you can, all the things, all that energy you were putting into you can now put in. Instead of buying bongs and roach clips, now you can buy lures and things. But at least you're buying, it's a nice way. So that's the answer to that. But they got to find that thing, and it's not an instant switch because nothing's going to feel as good. But long term, so much more rewarding to have that constructive thing.
Do a lot of alcoholics have death wishes?
No.
No?
A death? I don't think anybody. A death wish? I'm sure there's some people out there. I don't know. No, I think that. No, it's wanting to die. I mean, you're looking at depression on top of it. But no, I think the general instinct is to want to be happy and to want to live. But it just sometimes, I had somebody, one of my ex-clients who also is now an intern at CPC, and she's a fascinating person. She was a lawyer, lost her law license and everything, and she's doing so well now, and she's getting her master's degree. And I say to her, like, it's hard for me to believe, like she was, you name it, she was doing it, homeless, all that stuff, lost her kids. But I'm like the person I know now, it's so hard for me to imagine you like that. And she's like, there was a point where I could never imagine. So you talk about a death wish, to think, she's like, I could never imagine having a normal life. She's like, imagine looking at a bridge and you could see the other side, but it's filled with mines and barbed wire, and you're like, there's no way I'm going to get across this bridge. So maybe that's what you're talking about, this death wish. Some people just see like, yeah, recovery seems like such a fantasy to me, but you just all you got to do is take a few baby steps forward, and that's it. That's how you get across that bridge. And next thing you know, you're like, wow, I can see the other side clearer and clearer. So it is a process. It takes a while, and it's a lot of work. But
Like 10 minutes.
what's that?
Yeah, about 10, 15 minutes.
Okay. Any other ones? Go bang out one more question. Come on.
No
So the
student
scenario.
examples lurking.
Student example.
No.
Nothing. Let me see if I have anything else to say. Okay. So just as far as if you want to be better at this, as far as one things that you can work on, as far as being able to handle this better. One of your greatest tools is empathy. Is trying to put yourself in someone else's shoes. Because it's easy to, especially when you're in an authority position, it's easy to say, I'm the teacher and you're the student, and you should be listening to me. And, that sounds like that's a recipe for getting your students to hate your guts, really, because that's not what it's about. It's about remembering what it's like to be in that situation. And, or maybe you have no idea what it's like, but trying to understand what's it like, what must it be like to be in class and to have to go out to the car and smoke weed because you can't get through the class. Instead of judging that person and say, wow, that's probably a really hard situation to deal with, or anything to what would drive to bring the people to the different situations. I've been training counselors for years. I always say empathy is your greatest tool. You never want to lose that. You never want to be that person who sits on the pedestal and forgets what it's like. I was doing one of these things once, and somebody who had family situations, similar to what you were bringing up, and they said to me, they were really mad, and they were like, addiction is a choice, and I think it's a choice. And did I tell the story last time? I'll tell it anyway. And the person was very mad, and they clearly had some issues from her, her childhood. And I was like, well, think about it like this. If addiction is a choice, think about a choice using empathy. What's something most people can identify with? Food, right? Almost there's those people out there that just are, there's that maybe whatever percentile of society that just doesn't gain weight. They eat whatever they want, they have like supernatural appetite control. That's not the norm. Most people are like, they want to eat and they don't want to be fat, for lack of a better word, right? Or overweight. I'm always struggling. I was off for 2 days. I just pigged out myself for the past 2 days, basically. But it's a struggle, and most people understand that struggle. So if addiction is a choice, shouldn't theoretically speaking, shouldn't everybody be thin? Because shouldn't not eating too much be a choice? And everybody just be able to, hey, I'm just going to eat healthy. And it's a choice, right? Why not? Shouldn't it be that easy? Everybody should be in great shape. I'm going to choose to exercise. So yet most of us don't make that choice. So how are we going to expect something like addiction, which is 50 billion times harder than losing weight, and say that they should just choose to say no? So that's something to keep in mind. All right, any other last second scenario? Oh, here we go.
It's not
Or whatever. Comment?
Oh, can you hear, Sergey, can you hear him over there with that microphone?
Better mic, if you can. Can you give me
I have a question about the approach to treatment.
Sure.
There used to be a psychologist on the radio in New York, and whenever he would always talk about the patient's physical situation first to make sure they didn't have things like diabetes, stuff like that can affect mood. Does that apply here? I mean, is this only about dealing with the person from a psychological perspective, or is there, you know what I mean? I mean, if you're gonna make the analogy to food, you know what I mean? Like there's a lot of this is biochemical. I mean,
Yes.
that's what we're talking about is biochemical, and as I'm saying this, I'm remembering one of the things that he said was, this guy used to say, he's since passed, but he used to say that don't judge a heroin addict, because heroin might have been what saved their lives, because they couldn't deal with whatever it was they had to deal with. It gave them enough of a pause to kind of get past that.
Yeah, great way to end this,
physical.
because that is the future of behavioral health. CPC is what's called the CCBHC, and without getting into the whole complexity of that model, it's an integration model, and it's about integrating physical and medical with mental with addiction. In the future, it will be all in one-stop shopping, where you go to get your you go see your doctor. He'll make sure you're not losing control of any substances. He will also check your depression, because that's what it should be. Yes. So the answer is absolutely that is one. It's all interrelated. So many of the things, what they're just finding out between the brain and the gut in terms of the connection, with all that stuff. Absolutely, 100% on the right track. In the future will be full integration. It'll be a holistic medical, mental, physical, all one, because it's 100% interrelated. And when somebody has a mental health or substance use disorder, they are so much more likely to die of a medical disorder than the regular public. It's outrageous how much severe that is. Do I have time for one last, or we got to wrap it up? Oh, Sheila.
I've really been thinking about, Meg, your original question, and I think that there's a little confusion here. I don't think there's anything wrong with you saying to a student, we have counselors here that can help you if you want it. If you want to, here are the people. And what we can't do is we can't reach out to them. So in other words, you can't call us and say, hey, this kid is going out smoking pot every class time, and do you mind getting in touch with him? That we can't do. But I don't think there's any, and my colleagues are here and they can tell me if I'm wrong or if you agree. But yeah, you can definitely give our numbers.
I just want to thank you for the presentation. Very informative. And most especially, I enjoyed the fact that you did not use a PowerPoint.
Oh, wow.
Very refreshing.
Okay, cool.
Yeah, I guess.
People are addicted to it.
Thanks. Yeah.
Addicted to it. Yeah.
I guess,
All right.
Kathy, what I was thinking of is, could I approach a student and say, boy, you have it seems to me like you have an addiction, or it's like we can't do that, but it's the softer approach that I notice you're really sleepy in class every day. Are you okay? It's more of what. That's I'm just saying. Watch our language.
In terms of how it's affecting progress in your course.
Progress in the course.
And
got
then
it.
Send them
Right.
to us.
And let the kid know you care. That's
Right.
really.
Right. Sorry. Yeah.
And one of the things that we've seen happen in the past, from a counseling point of view, is that, and this happens a lot in your area, where the student and the person, the teacher, say for example, would say, not just we have people, but why don't you come into my office here, and if you want, we can make the call and set up an appointment. And lots of times, if you have already developed that kind of trust with that and rapport, that works really well. And it helps the student make that decision and then has something concrete for follow-up. Whereas on their own, they may slide back off of the decision,
That's
Yep.
a really good point.
Yeah.
And just hitchhiking on that, when that happens, the student is much more open right away, because they already have some trust in you, and you introduce us as someone who's competent and will take care of them. It's a lot easier to get going because of that. So.
And the phone number, by the way, it's to make an appointment with a counselor, just so everyone knows, it's 732, and you can give this to students, 224-2986. I got it right? Yeah, 224-2986. You can give that to students, and that's to set up an appointment, a free appointment with a counselor here at Brookdale, licensed counselor. So psychological counseling. So
That's slightly different.
Yeah.
okay.
You could pass those around, maybe.
And then there are we have Kathy in STEM and health sciences. Dawn is over in social sciences and business, and Ellie Horgan's in the humanities. So they're now out of wherever you were before MacMan, wherever you were Mass. You're in there now in Larison Hall and close to these faculty. So let's make sure they know.
Like Steve Curto alluded to in one of the other ones of these workshops, we can do the triage. And if we think that they need, a higher level than, we're here to give them, certainly we would send them to Steve's office as well, to that mental health area.
How would you differentiate whether or not they were nodding because they're exhausted from working 5 jobs to pay for school and being, like you said, respectfully suspicious?
You may not. I mean, usually if someone's nodding from opiates,
Just tired.
it's a little. I mean, yeah. You might not know, but like a real heroin nod is very. It's pronounced. Oh yeah, but you can ask. Right. You don't necessarily have to. You ask the question. You don't know. As long as you're putting it out there that you noticed. Yeah.
I just use another example. My husband used to teach here part-time, and he was in the Freehold campus, and he had a kid leave at the break every day and come back late. And after class one day, he was like, what's happening? Is everything all right? And he said he would get so anxious, this was in the computer 129 class, about what he needed to do and learn. His addiction was McDonald's. He would run out, and he had to have some food like that to reduce his anxiety. And the same thing, Michael said to him, well, we have people, blah, 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 blah. I think he probably gave him my number. But whatever it was, I mean, it's the same type. It's okay to ask.
Right.
And that's what we have a lot of trouble with.
That will probably kill you quicker than the drugs will.
Right,
McDonald's.
but it also, from our point of view, we wish more people would take that risk with the student, like you said, and not be afraid.
Don't be afraid.
To just say, look, something looks like it's happening here. What's going on?
Yep. People say it all the time. I wish somebody would have said something to me earlier. Yeah.
And sometimes what I'm getting a lot in my new position, sometimes the students feel trapped and faculty feel trapped. Like, what do I do to help them academically? We do have incompletes. There are things we can do to help students if the faculty member is willing to work with them. We can give a student 2 more weeks to get something done if they're going through a crisis. So just be creative, talk to your deans. There are things we can do at Brookdale to help the students. And I know everyone's thinking, they're just looking for an excuse. But I think we all know the difference when someone's really having an issue versus just kind of a slacker.
What's the worst that can happen?
And the worst is you take a chance,
so
and maybe it is a slacker. Maybe you just take a chance on that person sometimes. And I sleep better at night when I,
of course, you'd rather err on the side of
I take that risk. So. Anything else? Because
I think we're over time.
We're just a little over. We started a little late. Alex, do you have something else?
I was just going to say, I think I had a student one time, and I don't know if it's just something I've exaggerated in my head, that lost 3 grandmothers in 1 semester.
Yeah, how does that happen? All right. Well, thank you all for being here. Ken, thank you.
Yes, yeah.
We're wrapping it up.
Thank you.
Thanks.
Take care, everybody.